I conducted my systematic review, my doctoral experience, and my capstone project exploring the relationship between occupational therapy intervention and readmissions for patients with congestive heart failure. CHF places a significant financial burden on the United States healthcare system. It is estimated that by the year 2030, the direct cost associated with patient care for this population will rise to $53 billion. Unplanned hospital readmissions contribute significantly to this overall spending. In 2016, researchers from Johns Hopkins University and the University of Maryland School of Medicine conducted a research study and determined that occupational therapy was the only spending category where additional spending had a significant association with lower readmission rates for 3 patient populations, including heart failure. So for my systematic review, I started with this broader PICO question of an individuals with congestive heart failure, what factors contribute to hospital readmission? And in particular, I was interested in those factors that were within the scope of occupational therapy. After completion of the PRISMA process, I ended up with 36 studies included in the final qualitative synthesis. And what I found was that the factors associated with readmission for patients with congestive heart failure fell into these 2 broader categories of protective factors and risk factors for readmission. In this table here, I've outlined those protective and risk factors and have starred those factors that are within the scope of occupational therapy. So the results of the review suggested that higher hospital spending on occupational therapy intervention, particularly focused on these areas that were identified by the literature as associated with readmission and within the scope of occupational therapy, may result in decreased readmission rates for patients with congestive heart failure. So my doctoral experience took place at Riverside Methodist Hospital in Columbus, Ohio, and really my primary on-site role was to gain a thorough understanding of the continuum of care for patients with congestive heart failure. I participated in a variety of supplemental activities and projects while at Riverside, and in particular, I got to participate in interdisciplinary interviews and observation, as well as the observation of care across a variety of different settings. Now, prior to any on-site experience, really, I was recommending to my site an all-encompassing intervention protocol focused on those 5 factors identified within the literature as within the scope of occupational therapy. However, once on site, through conversation with my site mentor, we realized that perhaps this packaged program that was really all-encompassing for those factors identified within the literature was not necessarily appropriate for implementation at this time. And really, since there was so much interdisciplinary involvement across a variety of different settings, I first needed to gain an understanding of what the current continuum of care looked like for patients with heart failure. And so I underwent an implementation analysis where my 2 primary goals were to gain an understanding of each discipline's role within the care of patients with congestive heart failure, and to gain an understanding of occupational therapy's process of care for patients with heart failure. And one way I did this was through the conduction of interdisciplinary interviews and observations. So I had a standardized questionnaire that I would ask each discipline, and the last question on that questionnaire was if the discipline recognized or identified any gap in care, any opportunity for increased occupational therapy intervention to decrease readmissions for this patient population. So really, I wanted to use the insight from the literature, the insight from this interdisciplinary feedback, and my clinical experience with the patient population to identify logical opportunities for increased occupational therapy intervention. So after patient care with this population, and after identifying that there was consistency in the areas that the literature identified as important for occupational therapy intervention, and the areas that the team identified as important for occupational therapy intervention, I identified a multitude of opportunity for increased occupational therapy that I have outlined in this process map right here. I identified the most opportunity in the evaluation and intervention component of care within the areas of cognitive and health literacy assessment, patient mobility, and caregiver involvement. And although there's not a one-to-one correlation between these 3 components and the 5 factors that were identified in the literature, it was determined through patient care and through collaboration with the interdisciplinary team that occupational therapy intervention in these 3 areas is how we can best support patients discharging from the hospital with the required supports and services needed to participate in their CHF disease management. I identified 2 areas for priority where immediate and effective change could take place in everyday therapy sessions, and those were in the areas of cognitive and health literacy screening and increasing patient mobility during the hospital stay. I will now take some time to answer questions regarding my poster. The first question is about the AIDIT training. So the AIDIT training was really a hospital-wide initiative for all staff members to participate in this training. And AIDIT itself stands for Acknowledge, Introduce, Duration, Expectation, and Thank You. And so we were provided through this training, we were provided with a communication framework to guide not only interprofessional communication, but also patient care communication. The second question is regarding a further explanation of this "Are referrals sufficient?" bubble. And so while I was at Riverside on the 2 units that I was on, we were keeping track of the amount of patients who had heart failure compared to the amount of those patients that received an occupational therapy consult. And we determined that only 65% of the patients on those units that had heart failure were receiving occupational therapy. So really, we were just exploring this to answer these 2 questions. Are we getting the consults early enough during the hospital stay? And are we getting enough consults in general for this patient population? And the third question is regarding a further explanation of this gas gauge analogy bubble. So part of our intervention with patients who have congestive heart failure is energy conservation training. And one way that we teach patients about energy conservation is through providing them with a tool to monitor their energy exertion. And right now, Riverside was using the Borg scale to provide patients with that tool to monitor their own energy exertion. What I was finding was that the scale itself was not necessarily intuitive for patients or approachable to patients, particularly with varying levels of cognitive and health literacy abilities. And so I modified that scale into a simplified gas gauge analogy. And what I was finding that with this simplified version for a patient to monitor their energy exertion, I was seeing increased carryover from one patient session to the next, and increased comprehension of monitoring energy exertion in general. So that was just one small change that I made while I was at Riverside. Thank you for your time.